right, welcome to the Strength and Chiro podcast. This is episode 8. Well, I think it's episode 8. Can we get a check on that, Stephen?
Yes.
Yes, you got it down.
I actually knew it this time.
You were prepped by the producers this time and you knew it. Fantastic. Yeah, episode 8, season 2. Today we are having an in-house podcast. It's me and Dr. Stephen, and we're going to be talking about various things, some interesting things that have been happening lately, some kind of things that we've been chatting about that are on our mind. We're also looking forward to having a few more episodes in this season as we finish out the year, and we've got some really awesome guests lined up for that. I call him Red Mon. It's Red Min. Welcome to your own podcast. Co-host, Dr. Stephen Redmond, the Tony Stark of chiropractic.
That's what I've been told.
You've got your shaded glasses on, you're ready to go. I'm not sure what's happening under there. You've got some internal AI happening under there, right? Artificial intelligence, so your glasses. Okay, so how have you been, Stephen? How are you going since the last podcast? Give us any updates. Do you have any updates for us?
I've been well. I was out for a little bit with a little pec injury. Back to exercising and getting my full capacity.
Yep.
So sore everywhere again all the time, which is lovely.
Exactly right. It's almost, you can wear it like it's like a badge of honor. After I used to always squat on Monday. My workmates would know on a Tuesday morning when we would walk up to the coffee machine. There was 4 flights of stairs from our office to the coffee machine. In my heyday when I was powerlifting, everyone knew if I wasn't crawling up those stairs in agony, I didn't work hard enough. It was a little bit of a litmus test. Those in my community to stay involved whether or not I was working hard. Before we move on, thanks to everybody that listened to the last podcast. We had a lot of really positive feedback. We're really happy that people were able to get something out of that. I mean, it was fun for us being able to kind of be shoulder to shoulder, digitally at least, with some really brilliant minds. And I've got so much respect for every single person that was on that podcast. So if you haven't and you're listening to this, make a note to go back and watch episode 7 of season 2, the Ultimate Myth Busting podcast, where we absolutely sliced and diced and busted through 9 common myths that are kind of in the strength, rehab, manual therapy space. And every one of those was brilliant. So today we're going to start off with legit or bullshit with Stephen. This will actually be the first one Stephen's ever done. Then we're going to look at a recent meta-analysis that looks at the strength training effect on school-age academic outcomes. Then I want to talk about tendons for a bit, because I like my tendon talk. And we're going to finish off talking about some collagen-type Neo-innervation / angiogenesis for lumbar intervertebral discs, because I think that'll be something interesting to touch on. Welcome to legit or bullshit. You know the rules of the game. I want a legit or a bullshit. That means no, or maybe. Okay, that's the rules of the game. For those that are listening, yes, it's meant to be provocative. It's fun. Don't take offense, and you'll be okay. Don't steal fences. Do you get it? Don't take offense. Yeah, I'm a dad. Dad jokes. I'm a dad, man. I'm going to have 2. I'm going to be a dad of 2 in November. Stephen, are you ready?
I don't know.
All right. Here we go. NSAIDs and rest for tendinopathy.
Bullshit.
Activator, the tool, not the method.
The tool is amazing. Legit.
Activator, the method.
Bullshit, unless you just like to make your patients dance for fun.
Toggling upper cervical misalignments.
I'm going to say bullshit just because you said misalignment. Toggle as a technique is not something I would ever do, but maybe it has its place. But yeah, no, I'm not toggling anyone's upper cervical for any purposes.
Not always necessarily adjusting a patient during every appointment.
Oh, legit. Not everyone needs it. Not everyone wants it. Needs and wants are important.
Ron said X-ray line analysis.
That's the biggest crock of shit ever. I have PTSD from those classes.
Touche. Technique doesn't matter. Lift how you want.
Lift how you want if you want to risk getting injured. It's bullshit.
Integrating chiropractic adjustments and exercise rehabilitation into your treatment protocols.
That is legit. There's plenty of research, all the evidence informed, all the evidence-based practitioners will say that. Even some of the kookier people will say that that is accurate because it is. Everyone knows it.
CrossFit.
That's legit. Some people do it the wrong way.
Chiropractors specifically advertising towards parents, claiming that they can heal asthma, colic, bedwetting, cognitive, and emotional issues.
That's bullshit and a scam.
Sitting is the new smoking.
That's bullshit.
So, you know,
But smoking and sitting, you cannot compare those two.
that's an interesting one because there's some people in the industry that are saying that I respect, but I would say bullshit as well. They're not the same thing. Ice for acute injuries.
I'm gonna say bullshit, but if you like to hurt yourself with ice so you get numb, go ahead. That's exactly what I tell my patients. I'd rather you do heat and movement. But yeah, if you like to ice yourself, if you like to inflict that pain before the numbness, sure, go ahead. I hate ice. I will never ice anything.
Do you think there's ever a appropriate situation for ice to be used in any stage of the rehab process or acute injury?
Yes, if you're trying to mitigate inflammation early on for whatever reason.
One of the ideologies around it is in the 90s and the 80s, they were saying that you ice because you try to reduce that secondary injury that can happen if the inflammatory response gets out of control and then you have more tissue damage. But obviously, more research has come out since then over the last few decades. We're at this point now where we know that impeding the body's inflammatory process doesn't seem like the smartest thing to do, as you said, unless there is the need that kind of supersedes that principle, which would be return to play rapidly if you're an athlete. I understand being in that mindset of an athlete myself. Sometimes you're going to go out there and you're going to have to keep moving. And so ice can be done for that. Or in certain situations, as you kind of just laid out yourself, especially for comfort for some people. I think obviously it comes down to just being educated. Anyway, so Stephen, how important do you think resistance training is?
Resistance training is extremely important. We know that it helps prevent early onset Alzheimer's, and with this meta-analysis that was just recently published this summer, it shows that it may have a slight positive increase the academic world as well with children. We're talking about the benefits of resistance training being cognitive in nature and spanning the entire life frame of a human. Like that's pretty important. And it's such an easy thing to do. Resistance training doesn't mean going in and doing like one rep maxes and hitting PRs every day. It could be body weight, it could be resistance bands, it could be any kind of resistance. And that's going to vary depending on where you're at in life and what you have access to. But there's no reason not to do resistance training.
Yeah, and when you look at the literature, obviously it's very overwhelming when you look at resistance training paired with cardiovascular training, just the overall effect it has on one's health. We're not just talking one system, benefits to the musculoskeletal system or the cardiovascular system or the respiratory system or endocrine system. We're talking reduction in all-cause mortality, overall improvement in mobility, muscle strength and size, flexibility, balance, sleep, stamina, muscle to fat ratio, bone density, increased movement control, proprioceptive ability, increased functional independence, decrease of risk injury, enhanced performance. It helps manage pain. It can decrease blood pressure. It can help reduce and prevent cognitive decline, which we're going to talk a little bit about. It can improve insulin sensitivity. It can prevent or help control chronic conditions such as diabetes, heart disease, arthritis, back pain, depression, and obesity. So it is very clear that strength or resistance training is medicine. Now, it's not lost on me that some people can be a little bit intimidated, especially when you have people that are powerlifters or in the strength industry like myself preaching strength as medicine. You know, as you said, you hit the nail on the head, man. It's not necessarily strength. I like to call it strength. I like to say strength is medicine because it resonates with me and my where I am and where I've come from and my experiences and my worldview. But as you said, as resistance training, period. And you can achieve that in many different ways. And the most important thing is that you're progressing. So as long as you're progressing through whatever you're doing and you're building up your capacity, you're going to be moving forward physiologically. You're going to be getting stronger. You're going to be becoming just a better human being. Obviously, we understand now based on the stats, the poor outcomes from being sedentary. We understand that sitting around all day does have poor outcomes. And just adding activity on top of that doesn't necessarily cancel it out. So there's research now showing that they're independent factors. We say to people, get your 10,000 steps in, do your 10-minute walk, get your resistance training in. We should also address the cause. If you're sitting down all day, We need to get you up from that desk. We need to have you moving. We need to be implementing standing desks. We need to be trying to do other things, right? So by all means, I know it can be a little rich hearing a powerlifter sit here and say, well, strength fixes everything. And as much and as strong as the evidence is that resistance training is important, that's not actually the overall message. You got to meet your patient or your client where they're at, and you got to start implementing these small changes. And it can't just be adding on activity, although that's 1000% a place to start. Don't get me wrong, but it's going to be altering or changing what they're currently doing as well. How would you approach that in your office with your patients? How do you approach that discussion? Do you have that discussion? Do you not talk about it? When does it come up, if it comes up?
I do talk about it when people aren't doing anything. So on my intake form, like, I want to know if they're physically active and what are they doing.
Yeah.
And if they check yes and they don't explain why, or they list something that's something like walking, and I'm like, all right, walking's great, but they want to go forward from there, and I find out why they're not going further from there, and I figure out how to get them doing those things again. Resistance training is going to help indirectly, if not directly, with almost every complaint that comes in to my office. The more that I can empower them to do resistance training, the less they need me.
And that is a great point, right? It's shifting the reliance. Like, what are these people relying on? We don't want patients becoming a reliant on the provider, the medical provider. Oh, like progressively as they see you, you want to be trying to at least educate them, right, to live a healthier life. Is that kind of what you try to do?
Exactly.
And do you find other chiropractors don't do that? Or I should say practitioners in general, because it's across the board.
I'd say practitioners in general don't really do that. And if they do, it's very vaguely spoken about.
When Matthew Lewis spoke about some of those stats, and if you've hurt yourself in America, you're more likely to be prescribed a prescription of pain medication than a rehab protocol. So the myth that he was busting, right, the biggest myth he was saying under that myth is that people who don't get better with rehab need to be escalated to surgery or drugs instead of being escalated to a more specific rehab program. And I thought to myself, man, that's really bang on, because these people have probably gone to a physio or a chiro or an EP or an athletic trainer or whatever it looks like, and they've been given rehabilitation protocols or exercise, and it's probably template, one size fits all. It's probably a piece of paper that they've got in their office that they've just given to someone to get them started or get them going. And I understand how they justify it. They think, oh, we're just getting them started. I suppose the overarching importance here of the message we're trying to bring through is kind of specificity of care. And that's regardless of what is in your toolbox of interventions. Anyway, so let's talk about this study for a bit. So I wanted to bring this to the forefront of the podcast because I feel like it's important to talk about, especially as my boy's 5 years old. He's just started school. He loves TV. He loves to watch cartoons. You know, he's a young boy, and that's really normal for them. And it's trying to provide a routine where I'm getting him out of the house and I'm getting him moving. And it's what are other things I can do with him that's going to get him exercising. That's not exercise, but it's fun. And in New Zealand, we have a very strong sport culture. So it's very helpful for me. Every single person I know played rugby. I played rugby all through school. All my friends played rugby. It's just normal. Everyone played rugby. Everyone plays rugby. That's why we're the best in the world. 100%. Not even going to feel bad saying that. I think everyone agrees the All Blacks are the best in the world. Come on. Anyway, meta-analysis published in the Sports Medicine Journal, 2023, July 19th. Effects of resistance training on academic outcomes in school-aged youth, a systematic review and meta-analysis. We've got multiple authors on this, recently just been published. It's worth a read. It's worth a skim over for those that may not want to jump into and read the whole thing. I'm going to give you a little bit of a background right now. So the primary aim of this systematic review or meta-analysis was to investigate the effect of resistance training on academic outcomes in school-aged youth. So when we ask what is that age gap going to be kind of covering, 5 to 18 years old. Now, it's important to establish that because sometimes people will skew data and they'll shave off 16, 17, 18-year-olds to make the data look better, or they'll shave off 5, 6, 7, 8, up to 10 to make the data look better, specific to what they're trying to prove. So kudos to these guys for just saying full school age, 5 to 18, we're covering it all. Regardless of what it says, we're covering it all. They had 53 studies that were included in the systematic review. They concluded with this study, this review provides preliminary evidence that resistance training may improve cognitive function, academic performance, and on-task behaviors in school-age youth. Now, the interesting thing I found about this was resistance training was more effective than concurrent training, i.e., the combination of resistance training and aerobic training. Why would you think that would be the case, Stephen? Do you have any theories on that?
I have plenty of theories. I would say maybe the strongest theory that came to my mind when I read that was the fact that when we do resistance training, our brain is having to constantly adapt to different stresses and loads. And for the most part, like aerobic exercise is very redundant when you're just looking at like running in a treadmill in a controlled environment around an enclosed track or something like that. There's less neurological awareness of all the things happening, and then therefore there's less long-term neurological changes that your brain has to input those memories on.
Yeah, I would agree. And if we were to look into all 53 of these studies, I mean, we're not going to do that for the sake of time, but this is a meta-analysis. This is a review, right? So it's taken a bunch of studies and put it together. That's also why the overall effect on cognitive and academic on-task behavioral in school-age youth, that's why it's also very relevant to what we're talking about. It's because this is not just one study, right? Because obviously one study will always run the risk of being possibly incorrect based on the hypothesis, the p-value and the confidence intervals. So we're looking at multiple, not just 10, 20, 30. We're looking at 53 taken together and looked at. So it is quite significant. Now, if we were to pluck out each study and look at it, it would be interesting. How novel, how specific, what are they doing, right? So what is the resistance training versus what is the aerobic training? So overall, great study. I'll put it up on the screen for those that are interested. Go have a read, dig into the study, even dig into the individual studies and get a feel for really what they're trying to say. Because we don't have time to go into all that for now, but I thought it was worth at least bringing it up and having a quick chat about it. Here we go, man. Tendon talk. I want to have some tendon talk because you know what? We did this in episode one, I think episode 2, 3, 4, one of the early episodes when we first started the podcast. And at the time, we were very much talking about, we were very aware of the shift from tendonitis. Like we were very aware of the itis moving into an opathy or an osis. And we were very aware that, hey, there's now research coming out showing that what we thought was inflammation may not be inflammation. But I feel like we were still operating on a spectrum when we were talking about it. Not that it's wrong by all means. The Cook model that I want to touch on, I'll put it up on the screen. It'll be in the show notes. Me and Giles did a little bit of a collab and we talked about a little bit of it on social media. And it does provide an interesting alternative. So it's not new, but in terms of science and education, it's new. Something that was established not that long ago. It's likely not going to be taught in current curriculums. We've got people listening to this podcast that are therapists, clinicians, doctors, and they're constantly working with MSK rehabilitation. Tendons are, based on some metrics and some research, the most common MSK condition in patients seeking medical treatment. So it's important for people to have an idea. You've probably seen quite a lot of tendinopathy cases, is that right?
I've seen a few, yeah.
So it's pretty common. It's pretty common.
Yeah.
I know that I had a really bad case of tendonitis when I was younger and I went to the physio and he didn't help at all. And I remember I was really negative and I was saying to a friend, the physio is useless, they couldn't help me. And I remember my friend saying, well, tendonitis is actually quite complicated. And I remember thinking, isn't that 101? Isn't that literally their bread and butter? But turns out, it is actually quite complicated. So first things first, if you're still under the current paradigm or belief system that tendonitis is an inflammatory issue, it's probably time to do some more reading and educate yourself. If you're in the point now where you kind of understand it's possibly a spectrum and that people will come see you with an itis, it's either turned into an osis and become chronic, or it's still acute and it's an itis, that's fine. So I'm not sitting here saying that the Cook model is something that everyone has to practice. I just think it's something that everyone should at least be exposed to and understand. It's another way of thinking about tendon issues. Would you agree with that, Stephen?
I do agree, yes. I feel like with the Cook model, it really synthesized all the current understandings of it and just kind of mapped out a better game plan, but it doesn't make it better. It provides more for you to look at. If you were to maybe implement a biopsychosocial model of healthcare for tendinopathies, or you would probably you would go more with the Cook method than what we've done in the past, because they very much try to identify all the potential parameters around it instead of just identifying it as this or that and just going for that. Because it will work for some people, it'll work maybe for most people, but it won't work for everyone. Whereas the Cook method attempts to work for everybody.
Overall consensus I think we can all agree on is that tendinopathy in itself is caused by doing too much too soon, usually repetitive load and movement, one of those two. The traditional model, as defined by, I've got it in front of me here, defined by Bass 2012. Tendonitis is an inflammation of the tendon and results from micro tears that happen when the musculotendinous unit is actively overloaded with a tensile force that is too heavy and too sudden. Now, we're going to break it down real fast. What's the problem with that? When researchers started to look at these inflammatory cells and they started to take biopsies and look at what would be tendonitis, they started to see, rather than cells that are inflamed, right? So like an itis, they started to see cells that are degenerating. That kind of flipped it on its head. We're saying, hey, this is inflammation. Yet when we're looking at some of this research, we're not seeing cells that are inflamed at all. We're seeing almost the opposite. We're seeing an osis, cell death. Furthermore, we understand that treatments that have always been aimed at inflammation, such as steroid injections, NSAIDs, even rest, have never really had fantastic outcomes when it comes to treating tendons. That's pretty well known now, isn't it? If you're going to get a steroid injection, it's probably going to help with pain. Rest is probably going to help with pain, but it's probably not going to get the tendon better because tendon most likely is going to need load. I think that's pretty understood now across the board. Would you say?
Yes.
So yeah, when they looked at these cells, they don't see inflammation, they see degeneration. And that kind of flipped everyone on the head because everyone's like, no, it's big and it's puffy and it's red and it's all the signs of inflammation. It has to be inflammation. If it's not inflammation, what is it? And that's when Cook and Purdam came through and they said, hey, we've got a new continuum for tendon pathology. So Cook and Purdam proposed tendon pathology is not caused by inflammation or collagen tearing at all, but cellular changes sensitive to the matrix are hypothesized to be the primary driver of that pathology and that pain and even that swelling. Okay, so they state that inflammation exists, it can exist at various times, but it's not likely the critical driver of pain or the pathology, nor is the collagen tearing. The Cook model has 3 stages: reactive tendinopathy, so this is more acute, right? And this is accustomed with activity, overload, trauma. This provokes a non-inflammatory matrix response, so it's still swelling. We're still having metaplastic changes, abnormal tissue changes, tendon thickening, longitudinal separation. We're having a provocation of proliferation of cells into the area, an increase in proteoglycans, and it appears to be inflammation. But remember, inflammation is not the cause based on this model. The tendon at this point can heal if it's properly managed. The purpose of this phase is to act as a short-term adaptation to reduce stress, thicken the tissue, and increase stiffness. So at this point, it's almost like you can go back. Because a lot of the times we need to understand that the patient will be asymptomatic through this phase. They may progress through to stage 2, tendon disrepair. This becomes less acute and more chronic. In this stage, it's still trying to heal, but the tendon now has even more significant matrix breakdown, more swelling, more increased proteoglycans, and now we're getting more collagen separation and matrix disorganization. There is some reversibility at this point, but it becomes increasingly harder. Now, when we get to the third one, degenerative tendinopathy, this is more chronic. This is going to be your cell death, apoptosis, well-described regions of cell death, and disordered matrix areas, right? This point, there's little reversibility, but people say, well, if that's the prognosis, if that's the diagnosis, what do we do to help these people? Cook comes out and says, hey, we now shift to the healthy tissue and we train the healthy tissue. They go, what do you mean healthy tissue? This is a degenerative tendinopathy. This is phase 3. How can we treat this? You keep loading. And this is what they say. Why do you keep loading? Well, when they scanned Achilles or patellar tendons of 91 participants with ultrasound, they compared normal and pathological tendons. As expected, they found the pathological tendons were thicker and had more pathology, right? That's as expected. But here's the kicker. What they found between both tendons was that the pathological tendon had more good structure than the normal tendon. So what has happened is that as they have progressed into this phase 3, yes, there's pathology, but there's still good structure to load. And you've probably heard of this, Stephen, and the listeners. People will say, treat the donut, not the hole, meaning don't focus on what is lost. Let's focus on loading the healthy tissue. And that's really kind of the paradigm shift for the Cook model is, hey, even when someone comes to see you and they've been asymptomatic and now it's really sore and you look at it and in the past we've gone, oh, this is inflammation. So you need to rest and you need to ice and you need to do nothing. And if you come back in a month and it's still bad, we're going to give you a cortisol shot. We're going to give you a steroid shot. It just gets worse, right? So even at this point in stage 3, where there is cell death, there's still the ability to load. We have to load because we can now load those healthy tendons and load the healthy structure, which is still there based on this research. We can load these tendons and there's plenty of healthy tissue, quote, Cook. That's what she said. So pretty much, end of the day, tendons require load. We've heard this a lot. most people will agree that the traditional model of tendon rehabilitation to rest is operating under an old hypothesis. I think that's fair to say. The Cook and Purdom model prioritizes load, and that is the currency of tendon progression, right? So we're looking at progressing the tendon, not regression, progression, not rest. Neurostat ETL 2015 states mechanical signals are transduced via molecular signaling pathways that trigger adaptive responses in the tendon. So increasing mechanical forces causes this kind of adaptive response, resulting in more collagen fibers. Decreasing load results in less collagen fibers, right? So load is king, especially during stage 1. As you can recover, begin to load. People say, well, how do we do that, right? Because we're just going to make it worse. Incoming the magic pill. Now, I say that jokingly, but isometric loading, we all know it. I think eccentric loading has been very popular and isometric loading has been very popular, but it's often misused, probably the best way to say it. Obviously, when it comes to tendons, what is provocative to a tendon? Fast loading, store and release. Compression and energy storage can be provocative. So that is a problem. Now, on the other side of things, rest is a problem. So how do we marry up these two things? And Cook calls this the Goldilocks zone. And what they're pretty much trying to say is you need to find not too much, not too little, not too hot, not too cold. Ebony Rio, 2015, she came up with this isometric protocol. 5 sets of 45-second isometrics at 70% of max MVC, maximal voluntary contraction, will cause an extreme reduction in pain for up to 45 minutes. She's also reported that isometrics can remove cortical spinal inhibition, and she will refer to that as releasing the brake, so to speak. So I think that this is a very important part of tendon rehabilitation. If you want to read more about it, Rio ETL 2015, study named Isometric Exercise Induces Analgesia and Reduces Inhibition in Patellar Tendinopathy. And there's also more. So I'll put that up on the screen now. Go ahead, do more reading for yourself, make the decision for yourself. You, as the practitioner or the therapist, it has to be your own clinical rationale for why you do this. So do the research, do the time. I think your patients will thank you for it. Any thoughts on that, Steve?
Yeah, I just want to pick up on you were talking about Rio at the very end. While I was stopping myself from going down the rabbit hole, I ended up watching a lecture by her, and she was talking about the asymmetric loading, and she was also talking about something really interesting that I had heard a little bit about sometime somewhere. I don't remember where. I wish I could give them credit about using a metronome for rehab, especially with tendon loading, and making sure that we're doing that repeated loading appropriately. And she also mentioned like some visual stuff as well, which is really fascinating. And it just shows how much more there is to learn about rehab.
Yeah.
Because we know what we need to do, but sometimes our methods aren't the best. And she's got some research out there that shows that there are little nuances that we can still improve on and that the patient can then take home or their client can do side of what they're doing with the provider.
Yeah.
Like I know that there's an app I actually screenshotted. I'm gonna buy it just to play around with it. It was like $3.99 on the App Store, and it gives you access to those tools. And I think that's really fascinating because it allows you to take it home with you and do it outside of the clinic, which is really important because most people aren't going to spend all day, every day with their physio, with their chiro, or with their trainer. So if they have access to some of that equipment for as little as $4, like that's amazing.
Yeah, and it's cool that you brought that up because one of the things we like to do with this podcast is create solutions. And I hate to just bring up problems and never actually give the listener solutions. And it's so important because as clinicians, we're always looking for a better solution for our patients. So it's so important that we're focused on that. We're not just looking at what we can't do, but we're looking at what we can do. And what you're talking about, absolutely right. So the metronome training is called tendon neuroplastic training, and you're right. It is mostly created by Dr. Ebony Rio. So that would have been the video that you're watching. The whole point behind TNT training is it's kind of motor control deficiencies. So that's the corticospinal inhibition that we're talking about is linked to tendinopathy. So what we're looking at now is not just a tissue change and not just changes to the anatomy or the physiology of it or the structure of it. We're now having a cortical input, right? We're having changes to the brain, and especially going through chiro school, tons of kind of classes on neuroplasticity and how adjustments change the brain and things like that. When something goes wrong in the body, it will change the brain to an extent. And what Ebony found is, she would refer to it as the break. So you'd get somebody past those reactive stages or the degenerative stages, and you'd train the healthy tissue, you'd have a good program, but then you've still kind of got this clamp, and that would be called the cortical spinal inhibition. It's kind of this clamp that the brain's putting on because it's trying to protect the musculoskeletal system from further injuring itself. And so she came up with this thing called TNT training. This cortical changes, they can sometimes persist even once the tendon's fully healed. And it's been described by Dr. Ebony Rio, quote, a driver who has their foot on the gas and the brake at the same time. So that kind of frames the whole point of TNT for you a little bit. The end goal is to maximize rehabilitation and restore full function beyond just the peripheral or just the tissue dysfunction, right? This is achieved through metronome-paced strength training, MPST, instead of self-paced strength training, which is SPST. Ling et al. 2017 demonstrated that MPST, metronome-based, evoked more corticospinal changes than standard training. When you stop focusing on that kind of intrinsic and inward, okay, I'm training, I'm going through the motions, I'm doing the exercises that my PT gave me, and you start doing it to a kind of extrinsic, you start thinking, okay, metronome, or you're doing something else, you're going to evoke more corticospinal changes, which is what we want when we have a problem like this. So TNT is not only a strategy for improving motor control, but it also helps the patient stay engaged while they are providing another metric that can measure the patient's progression and rate of loading. So it helps on multiple fronts. So TNT training, tendon neuroplastic training, Dr. Ebony Rio. I'll again put it up on the screen. Go do your own due diligence, read up on it, and see how you feel about it. But I feel like this is, in conjunction with isometric and eccentric training for tendons, can be a fantastic implementation or intervention. Don't just take my word for it. Again, go Dr. Ebony Rio, go read the studies, understand it, and then integrate it into your treatments with your patients, because I think it's a fantastic idea. I would like to touch on pain. I know pain is really complicated. It's a very elusive topic. There are sensory nerve fibers that are located in the peritendon, so the peripheral tissue. However, there are a number of studies that show nerve ingrowth in pathological tendons. However, other research has suggested that those nerves can also be sympathetic in nature and control blood vessels, and they don't necessarily contribute to pain. Other pain theories include the separation of the collagen, biochemical stimulation. Lower limb tendon pain appears to be local, no central sensitization. Cook will say treatment is dictated by where the pain is in relation to the structure and the function, and that's what's going to dictate your implementation or how you're treating the patient. Pain can occur at any stage of the process or the Cook continuum, and normal tendons on imaging can be painful. Pathological tendons on imaging can be pain-free, and that's pretty much where I'm going to leave this. At the end of the day, treat the structure and the function in relation to the pain. So at the end of the day, there are a lot of ways to treat it. I'm not going to go through a full rehabilitation protocol, but we have our isometric loading, our eccentric loading, our isotonic slow heavy load, our energy storage, and then our specificity of sport. That's a real easy linear return to play function. So isometrics, eccentrics, isotonic, slow, heavy, that isotonics move through their own continuum of how you want to load them. And then energy storage, store and release, which is what tendons are known to be provocative for. So you want to be careful when you get to that point. And then specificity of sport. So how are we going to get that person back to sport? Now, this is a nice little linear table that I'm looking at, and I can put this on the screen as well. It's important to know, sometimes you don't know where they are in the scheme of things. You don't know where they are in terms of the spectrum or the continuum. So sometimes you really got to dig deep and find alternate strategies to get that person back on the field and also help them get through their tendon problem. So takeaways on the tendon so that we can wrap up. Reduce the load, down-regulate the pain. Isometrics are usually very safe. Graded exposure with load and quality movement is great. Isometrics, eccentrics, slow isotonics, TNT metronome work or alter velocity, improve capacity, progress to energy storage, and ultimately we want to return to play, sport or lifestyle specificity, and ultimately throughout the whole process finding that Goldilocks zone. Any thoughts on that to finish up tendon talk?
I thought that was pretty well discussed. But if you don't agree, just put it in the chat whenever you're reading this stuff or listening to little clips that Brogan puts on.
We always encourage discussion, but again, it's not that you need to disagree, but that you can bring a different perspective, because I'm not coming out saying that this is 100% right. I'm just trying to educate the listeners. I want everyone that's listening to this to be fully equipped to deal with what some of the research says is the most common complaint. So if it's such a common complaint, we need to be on the cutting edge of research. Now, there are people that think the Cook model is wrong, and they don't listen to that at all. There are people that still fully subscribe to the model that tendonitis is an itis and it's inflammatory, and that's how they treat it. They want to ice it, they want a steroid shot, they want to rest it. That's how they do it. Really, it's figuring out what you want to do, but I would urge I would urge you towards the side of at least having a spectrum understanding of tendinopathy, tendonitis, and tendinosis. If you don't know what each one means and where they fit, you need to, especially if you're a healthcare provider. And if you want to go further, then move into the Cook model. Because as I said, we're not just creating problems here. I've gone through and given you solutions. I've gone through and said, this is why isometrics can help and work. This is why TNT can help and work. Go read this paper. Go read this paper. We're equipping people with this podcast. We're not just sitting here talking shit. We're not just sitting here pulling other people down. We're actually giving you the research and then clinical experience. Is there anything you want to add in your experience dealing with tendons?
I haven't really seen anything where the tendon is just like acutely very swollen. I mean, I've seen some cases where there's some acute inflammation, but for the most part, I tend to see more chronic than acute. I do see acute, but just maybe 25% of my patient demographic is acute injury. The rest of it's chronic. And so I see more of the chronic and degenerative. And what I've seen some MRIs that show some tearing on tendons, and I'm seeing the patient, and I'm like, there's some good tissue in there though. Like, so it was really interesting to go back and learn more about what Cook has found out about it. Because I'm like, yeah, I've seen that with my eyes, like grossly without being able to look at the tissue itself. I'm like, no, they can still load that perfectly fine. It hurts, but we can change things, we can adapt things around. It was really enlightening to listen to her model, read about it, and watch the lecture she gave 5 years ago, I think.
Yeah, she's done some really good lectures. Go on YouTube, listen to it all. She's fantastic. She's been on various podcasts. She's been on Aaron's Squat You, our friend's podcast. She is really, really easy to kind of understand. So I think she does a fantastic job at that. Her name is Jill Cook, if you want to look her up. Obviously, she's a specialist in musculoskeletal injury, and she's from Australia. Funny enough, Dr. Locke she taught Dr. Locke, and he said she was really, really awesome. Okay. So we're going to move on to the last thing that I want to talk about. Obviously, there's this debate going on that technique matters under load versus people saying move how you want, have a loose belly, trust yourself. And then there's kind of this argument like, okay, is flexion under load okay? So you've got people on social media loading up Jefferson Kills and thus saying like, hey, I'm fine and I'm not hurting myself. And then you've got people on the other side being like, yeah, well, it's a spectrum, it's a continuum. Like you're delaminating the fibers of the collagen in your annulus, and over time that's going to cause problems. So you're young and healthy now, but you're probably going to have problems down the road. Part of my thesis that I've been working on here, I wanted to talk about genetic variation. One thing that we don't talk about enough is the genetic variation of collagen types within the annulus. And why is this important? Well, it almost appeases both arguments. So you can almost say, yeah, flexion under load is probably not a good idea, and you're probably going to have some delamination of the annulus if that's your belief system. And you can also say some people can train as hard as they want, and their annulus is either going to adapt or it's strong enough to handle it, and they're going to feel great. Two different ideologies. So let's have a little bit of a deep dive into this. So various types of lower back pain, as we know. If we want to be able to treat back pain efficiently, we need to understand the structure of the spine, the anatomy, the physiology, the molecular spectrum. And like most things, there's going to be a spectrum, especially in biology, right? So a spectrum seems to exist between the type of collagen, the amount of collagen, and the ratios between the types of collagen. Research has shown that there's up to 28 types of collagen, and each one, although similar in the structure and makeup, have a different role and physiological presentation within the body that differs from type to type. Some are similar, some are very, very same, some are different. The average person will know this, and we know this as clinicians and therapists. Collagen makes up bone, teeth, hair, skin, fascia, muscles, more of that, right? The stiffness, the elasticity, the density, durability, the capacity to adapt to stress or be injured, ruptured, or damaged changes with each collagen expression. Now that makes sense. Various research shows different ratios of collagen types within the annulus. Does this not make it plausible that each individual person may be working within their own God-given spectrum? Does it not make sense that people that are on Instagram doing all these types of workouts, I mean, there are certain powerlifters that were able to deadlift in a certain way where they have fully flexed over to increase their biomechanical leverage and they had no back problems. Is it likely or plausible that we're all working with our own spectrum of God-given genetics? This may change due to various factors over the course of one's life. So if we're operating under the belief that this hypothesis is correct, which is what the research says, this could potentially mean that some people are simply at just greater risk of discogenic injury. So other Others can get away with more, can take more risks. Other people can take less risks. So there's variations, right? Some people can do more than other things, and we're all different as humans. There's a spectrum, biological spectrum. Others can get away with taking more risks. This is nothing new, right? So as researchers, they've been aware of this for decades, but it's important for therapists and clinicians that we understand this. This is why I'm bringing it up, because we're the ones that are treating lower back pain on a day-to-day basis. When asked why some outliers can break the rules and succeed, Professor Stuart McGill said this: there is a spectrum of collagen types in the human population. One of them is more resistant to motion, so you can roll the dice now and hope that that's not you and you'll get away with it, and some do. Does that not tie it together nicely? So does the IVD have two types? Well, yes and no. Borum et al. 2018 described the annulus fibrosis as 15 to 25 concentric laminae of collagen consisting of collagen type 1 with an extracellular matrix consisting of aggrecan and collagen type 2 and a ground substance of elastin, collagen type 2, various types of collagen type 1 and type 6. Boulder 2018 described the annulus fibrosis as mainly collagen type 1, comprising of 7 to 15 concentric layers. Another study in 2017 reported that diabetes altered the structure of collagen within the annulus fibrosis. Many seem to agree that the primary type of collagen in the annulus fibrosis is type 1 and type 2, with outer kind of lamina consisting of type 1 and then transitioning into type 2 the deeper you get and the closer you get to the nucleus propulsus. There is also other research, though. Jen et al. 2013 reported other collagen types that were detected in the annulus fibrosis, such as 3, 5, 6, 9, and many other types. So if anything, this information only strengthens the importance of a comprehensive history and a thorough assessment specific to the patient in front of you. Don't go off your nut watching social media, going through Instagram, and that leading how you're going to treat your patient. General, non-specific claims about disc mechanics commonly seen on social media by therapists and clinicians are not helpful, causing more tension and division between professions and possibly more harm than good. Interventions and treatments should be appropriately applied to the patient as needed, depending on the findings of the healthcare professional. Understanding that these differences can exist may possibly enable therapists and clinicians to provide more specific patient-centered care rather than following non-specific broad protocols that have been perpetuated through the industry by poor misinterpretations of cadaver research. What is your thoughts about that as a clinician, Steve?
I fully support it based off of what I've seen clinically. Some people can do all sorts of things, and I'm always amazed that they don't get injured, whereas other people almost seem almost prone to injury. They're not really prone to injury, but we have to take into account past traumas and things like that. So it's not really like they're prone to injury, but maybe they had trauma a long time ago and now their tissues, the collagen fibers, never fully got back to where they were prior. So they're just predisposed to early injury.
And the hard thing, right, is as clinicians, how do we know? How do we know? And it comes
We
back to
don't
what?
until we find out.
Until we find out. How do we find out?
Yeah.
Comprehensive history, comprehensive assessment. So with your patients, how do you get to know your patients in order for you to give them the best care possible?
I definitely don't get to know them in one visit. It takes time.
Exactly.
It's a slow rollout, and I don't see my patients as frequently as other chiropractors do. So sometimes it does take a bit longer because some people don't like to talk about themselves. I know when I'm the patient, I don't want to spend 5 hours talking about myself. So it depends.
And it's about asking the right questions, right?
Yes, you have to ask the right questions. If you don't ask the right questions, you'll never get the information you want. You may get close to it, but you'll never get exactly what you want until you ask the question that's going to give you that information. If you just go off of slightly edging into it, you're going to make broad assumptions, and those assumptions may be proven wrong by you giving them the wrong tools to success, and they end up being tools to kind of some brief failure as we get more tissue trauma than we were expecting.
Exactly right. So, the whole point of this segment, I think, if anything, is just to say to the people listening, hey, I know we have people on both sides of the camps. We can get very passionate about what we believe. Technique matters, flexion under load is bad. You have to move a certain way in order to be to live happy and healthy and never have an injury. Like, I know that there are these kind of belief systems that we kind of subscribe to, and I do myself. But I think it's imperative that we take a step back, and at the very least, what I've just read through to you just highlights the importance of getting the time to do a comprehensive history, in-depth assessment of your patient, and then be a human. Talk to your patient, try to understand where they're coming from, kind of as what you were saying before. If you don't have a long time with them, McGill has 3 hours with a patient, Stephen has 30 minutes with a patient. Mofo will have an hour and a half with a patient. It's going to change based on who's listening to this. Use the time you have to ask the right questions, be a human, get to know them, and understand that there's going to be a spectrum and biological differences in these tissues, and you're just going to have to feel out where they are on that spectrum. It's not the most important governing factor by all means. Follow your normal protocols, but I definitely think it's an important concept to understand. I am interested to ask you, Stephen, in chiro school, what nerve were you told is responsible for innervating the IVD, the annulus
For the
fibrosus?
sinovertebral or the recurrent meningeal, whichever
Current
word you want to
meningeal
go by.
sinovertebral. So
And I still know that stuff.
you still know, right? So traditionally, we are taught that, you would agree, right? We're taught that the annulus fibrosis is innervated in the outer third or kind of the outer few millimeters of the disc.
Yes, yes.
And we are taught that it's meningeal branches or the sinovertebral nerve. Now, although that's true, there is research that indicates it's a little more complicated, showing that the IVD is supplied by a variety of nerves, including nerves derived from the ventral rami, the gray rami communicans, and 2 very dense interconnected plexuses, which are located throughout the anterior and posterior vertebral ligaments, among others. So there's actually research spanning back like the 90s, the 80s, the 70s, hypothesizing and theorizing and talking about various innovations of the annulus, which is interesting. Regardless of that, many would still consider the IVD to be a fairly avascular structure. Would you agree to that?
Yes.
It's still fairly avascular, isn't it? Like, it's still collagen, right? With very little ingrowth or blood vessels present. And I suppose it's interesting to ask yourself why that is. I've heard McGill talk about that he's been involved with some younger cadavers, and he said that there's been no innervation, no nerve innervation. Not in the outer third, just not there at all. We're kind of taught that it's a certain way in the textbook, but in reality, when you dig into the research, it's not necessarily all it seems, which can change how you treat your patients. I think it's important to have this information. That's why I'm bringing it up. And so I'm briefly going to touch on IVD, Neo-innervation, and ingrowth and angiogenesis. That's the title of the segment. A 2021 scoping review covered 33 articles. They looked at numerous IVD tissue samples, like human tissue samples, not animal cadavers, concluding that the IVD innervation is detectable during the fetal period and it increases into adolescence. Okay, so it's there when they're young, and as you get older, you get more ingrowth and more angiogenesis. They found that the increased nerve fiber infiltration was associated with age-related degenerative changes or spine-related pathologies. So really what we're looking at here is kind of trauma and injury and degeneration over time. It's likely that the nerve ingrowth doesn't occur, or at least doesn't rapidly advance, until some form of degeneration, trauma, injury will occur, which is almost always associated with age. The pain generators that come with the lower back is numerous. So if someone comes in and they say, I've got a sore back, it's like, okay, where do I start? Disc degeneration, end plate defects, structural changes, annulus, height loss, fissures, biomechanical changes, radial fissures, herniation, strains, sprains, all have an association with pain. So understanding how spinal degeneration, trauma, and injury, and the association of that with neural infiltration is important to enhance our knowledge and help us treat our patients and lower back disorders. Would you agree?
Yes.
In 2012, Stefanakis et al. Conducted 3 complementary studies with human cadavers. Now, this is an interesting study. Researchers were able to create some clarity around the mechanism of which causes IVD, neuroinnervation, or angiogenesis. So the experiments showed a compressive stress reduction of 36 to 46% within the annulus fibrosis that sustained fissures compared to normal adjacent healthy structures. Additionally, biochemical analysis revealed 36 to 54% less proteoglycans among the discs with fissures. So what do you think that research kind of shows?
That there's lots of changes that happen that predispose the IVD and other structures to failing over time.
Yeah. right? So what we're seeing is the compressive stress is reduced once there's an injury to the annulus. Now, what does this mean? Okay, researchers concluded that the internal pressure of a healthy IVD was sufficient to inhibit nerve infiltration and angiogenesis. And conversely, annular fissures were conducive to neural and blood vessel ingrowth. These findings are consistent with many other findings in the literature as well. Stefanakis et al. 2012 once again concluded in his paper, and this is quote, proteoglycans inhibit neurite growth and endothelial cell migration in vitro, and high pressure would collapse those blood vessels. So annulus fissures seem to be mechanically and chemically conducive to ingrowth of nerves and blood vessels. So really what we're getting at and what we're seeing here is that there's research that show that Neo-innervation and ingrowth or angiogenesis within the outer third or even into the annulus fibrosus itself is correlated with age. Is it correlated with age due to degeneration, injury, or trauma over that time? It's hard to say, but we know that it's correlated with age, which is likely correlated with degeneration over time, which is correlated with injury and structural damage and trauma. When a disc is damaged, it loses its compressive internal pressure, which is what the research says, up to nearly 50%. That can cause, as the pressure goes down in the disc, which was stopping the ingrowth of Neo-innervation, it kind of opens the floodgates, so to speak, and allows for the ingrowth of nerves and blood vessels, thus more ability for your patient to feel pain, especially as they get older. This is just one piece of the pie, and this is just one aspect of what could be going on. And I just think it's important for therapists, clinicians, chiros, osteos, all of those EPs, all of us out there, just to understand that this is a possibility when we're looking into lower back problems, conditions, and pain triggers. This can absolutely be a pain trigger in the lower back. But it's just important to know that, hey, as people are getting older, there's likely going to be a positive correlation with an increase of Neo-innervation and angiogenesis. And I think knowing that can help at least shape how you're going to treat your patient. If a patient came in to see you, for example, do you adjust hot discs?
It depends.
Yeah. So it's not like a hard and fast rule, right?
No, no. And I also have access to a flexion distraction table,
Yeah.
and you can argue that's an adjustment or not. According to the insurance companies, that is an adjustment. I wouldn't really classify it as one, but the insurance companies say it is.
Really, like when it comes down to your clinical rationale of treating a patient, how do you streamline or how do you determine or DDX a lower back issue if someone comes in and they're presenting with very diffuse type lower back pain, which is probably quite common? Obviously, you're going to have the patients that come in and they're like, oh, okay, it's going down to my big toe. Okay, it's likely going to be a herniated disc, pressure on the nerve going down to the L5 nerve root, whatever. You're going to have those ones that are going to appear more simple. Although even saying that, you did just have a patient that was presenting that way and it wasn't that. So, but you get what I'm saying. What's your protocol? What's your process of trying to narrow that down? Because for people listening, I think that would kind of be helpful, especially with lower backs, which seem to be very confusing for people.
I ask lots of questions. I then do an exam. I do a full neuro exam for if it's lower extremity, then I do mostly a full neuro exam. Sometimes I don't do the discriminatory stuff. I feel like it's necessary. I do, but I do a thorough neuro exam and to rule in, rule out neuro things. And then once I get a picture on how involved it is with neuro or other tissue, then I attempt to stress and relieve those tissues, and the provocative and palliative measures end up pointing me towards which treatment approaches are best and also which diagnosis is most likely. But still, at the end of the day, I may not definitively have one diagnosis. I may be in between one or two. I may have a couple of them. It's a trial and error type thing. It's a song and a dance, and you just have to know the words and you figure out the words to your song and do the dance based off of your past experiences and your continuing ed stuff.
What if you could give some advice to someone that's graduating at the end of this year, or someone that's just graduated halfway through this year and they're just out in practice and they're just starting, and when someone comes through the doors with lower back pain, they kind of just panic because they don't know where to start? What kind of advice would you give that person?
Honestly, the best piece of advice I could give for a new grad or a soon to be new grad is I hate to plug a course. I mean, it's not my course, so I don't make any money. I don't care. But I just hate because there was a paywall behind it. But Philip Snell's Fix Your Own Back course for the clinician takes you through some stabilization, takes you through some neurodynamics, takes you through some MDT,
Cool.
shows you a thorough assessment for ruling out the SI joint versus the disc versus the facet, and it's really well done. It sets you up pretty good and lets you figure out what you do and what you don't know, and then you can then look into more of one of those things or even something just completely different
Yeah.
to complement that as well.
Very cool. I got the name here, and I'm going to put that on the screen for those that are listening, for those that are watching rather on YouTube. If you're listening on any of the many platforms that we have, jump over to YouTube if you want to be able to see the actual name, or maybe you were able to pick it up just from hearing Stephen talk about it. But as we often say, it's the professional, it's not the profession, So the first thing Dr. Locke says to people once you graduate is lose your religion. It can be hard, you've been taught to do things a certain way, and you've been taught to see a problem a certain way. Don't be afraid to lose your religion. Be humble, ask people for help.
Yes, my goal is to be function forward with my diagnosis for whatever it's worth. Maybe it's good, maybe it's a terrible idea, but I don't even generally give my patients a diagnosis. I document it, but I don't tell them what it is unless they specifically ask. Or certain patients, I just maybe they're a healthcare provider and they're more inclined to appreciate it at a different degree because a lot of people tend to cling on to a diagnosis and they become that diagnosis instead of letting that diagnosis be part of who they are.
Yep.
And so I don't jump to diagnose someone verbally. It's documented. It may change once I figure out more things going on with them. That's also a benefit of not being like, you have blah, blah, blah. Like, you have discogenic sciatic radiculopathy. Oh, you have some irritation. You have some inflammation that is potentially bothering these structures, which may present in this way, but it could be other things, but that's what it looks like right now.
Totally agree. I've got family members that have gone to musculoskeletal professionals, rather than, I'm not going to call out specific professions, and they've been told just these really strong kind of musculoskeletal medical diagnosis that is really, it's impacted kind of how they think about their own body. It's impacted how they think they can move. It's impacted whether they can go to work. It's really just, it's done more damage up here than it has in terms of the body. Having a healthcare professional sit there and tell you what is wrong with you with these big fancy words, and it just sounds so bad. Like you said before, like a lumbar radiculopathy, like, okay, it's gonna sound bad to a person. It doesn't mean that you can't say it, but it's kind of how you say it. And also sometimes it's just to upsell them. It's like, oh, you've got this, you've torn this, or you've done this, you need to come back for this many visits, when it may not be the case, or that person may be operating under a hypothesis based on their test, but it may not be accurate. But anyway, no, that was great. Okay, we'll close up. Any final thoughts?
Thank you, guys and gals, all you people, for continuing to listen to all of our episodes.
Absolutely. It's been good. I think we jumped from like 90 to 61 on the chiropractic. It's like out of like 500 or 900 podcasts.
That's because I just go on and I listen to the podcast on all these different accounts that I've made.
And you just repeat, yeah. So like we jumped to 60. I'm like, man, let's jump to number 1. No, hey, thanks for everyone that listens. Like you said, hopefully you are getting something out of it. Hopefully it's entertaining, but it's also educational. And thank you for listening to this one, even though it was an in-house, just me and Stephen, the OG duo. We are going to have some great guests. Like I said, this is episode 8. We got 2 more coming up before season 2 wraps up and the year wraps up, and we've got some really cool guests for you. You're going to love it, so stay tuned for that. Also, make sure you check out our social media, both Stephen and myself, as these clips will be posted to social media. If you haven't, go back and listen to episode 7 once again with some of the world's best rehab minded manual therapists, doctors, clinicians, in the world coming together to kind of bust some myths, some of the biggest myths in the industry. It's a really awesome episode, and if you haven't, please go check it out. It is up now on all major platforms. If you want to watch it, you can watch it on YouTube. Apart from that, thank you for listening. That's episode 8 done, and we will see you in the next one. All right, have a good one.
You too, bye.
See you, bro.